And what about the diarrhea or GI toxicity, I should say, with abemaciclib? How are you guys handling that? What do you get any hints you're giving patients for managing it? What about you, Kevin?
So we participated in the early study, and I remember in the back of my head when that drug was being developed, just the reiteration of you should let the patients know that this is a side effect, and that's always kind of stuck with me. That whenever we prescribe the abemaciclib, we say if this is the side effect to look out for, give us a call on the first sign of diarrhea. When you order the medicine, you can have the Imodium kit, so we make sure they have that at home. And then, if patients develop more than grade 1 diarrhea, so if it's a grade 2 diarrhea, then they hold the medication, and if it goes down to grade 1, they can resume at that same dose. But then if it's a recurrent issue, then they dose reduce. But I tend to, especially with the 150 dose, if you're giving it along with hormonal therapy, it tends to be manageable.
And you find the dose reduction, in those patients you need to, it does help. It does reduce the diarrhea. How about you, Hope? What's your experience been so far?
Yeah, it's so interesting. Having enrolled patients first in Monarch 1, where we gave a higher dose as a single agent, we did, and these were heavily pretreated patients, we did see some diarrhea, and then, they would hold drug, or they would give themselves Imodium, or they wouldn't eat the spicy food, Remember, one of my patients was always carried Imodium in her purse, so that she would have it in case. But then when we use the lower dose with hormone therapy, we just stopped seeing a lot of diarrhea. I mean, it's not of high grade, so they get some loose stools, but generally manage it pretty well with Imodium. I think one of the hardest things for some people is just figuring out which dietary things can set them off or not. And we see that with other medications as well, even pertuzumab, actually. So I haven't had a lot of problems with the diarrhea. And again, maybe it's a patient population issue.
How about you, Ruth?
No, nothing more to add. I agree with Kevin's management. I think it hasn't been as huge a problem, I think, as maybe we would have expected. So.
Yeah. My patients have all modified their diet. First of all, it seems to be the first 4 to 6 weeks anyway. After that, pretty much, except for a few patients who I did have to dose reduce. There were like 2 or 3 I did have to dose reduce, but everybody else has, basically they say, I have 1 or 2 loose stools a week is what they usually say, and they just take loperamide, But a lot of the ladies will modify their diet, as you said. Some will find it's a heavier spicy if they just stay away from the heavy spicy or just eat smaller amounts. Or some like one woman, she told me yesterday, if she eats a big salad, big fiber, she'll have a loose stool. But it's really quite manageable, and they can pinpoint what it is. So it is something that seems to be really kind of a non-issue for most patients. Any other toxicities that you guys have run into? Anything else?
I mean, fatigue, I think, is sometimes an issue. I certainly had a patient come off Pallas because she just got really bad fatigue. Now, she had chemo and radiation, but it seemed to be related. So that's the one other thing that I've seen. But apart from that, I think they're well tolerated, really.
Yeah. I mean, the other side effect that I now preemptively talk to patients about is alopecia. I do, just because I had one patient who experienced, and it's not like what we see with chemotherapy, but I had one patient who was upset by the fact that she was having some hair thinning. So that rate across all the different CDK4/6 inhibitors is slightly higher. So I do mention that to patients from the outset.
And that's pretty much across the board, do you think? That probably it's
about a third of the patients, but mostly it's grade 1, so it's hair thinning. But I did have one patient who has some kidney issue where she has renal insufficiency and her hair all fell out. It's my one patient. So you can see why there is occasional grade 2 alopecia. So I also tell everybody, because that's one of the things that people really get mad if you don't warn them. But the fatigue issue that Ruth mentioned, I've found to be a bigger issue in older patients in the metastatic setting. And yes, in the adjuvant setting, it's an issue for patients as well, regardless of age. But for the older patients, we have dose reduced for fatigue. And it was interesting, the FDA analysis of older patients found that they had more fatigue than younger women. So I think that, fatigue is a real issue. We use methylphenidate for those patients, sometimes with effect as well. But dose reducing and changing the schedule, again, that's one woman who's been on it now for several years, a CDK4/6 inhibitor, where we actually changed to 2 weeks on, 1 week off at 75 because she keeps being so tired. You know, she found it was a huge quality of life issue.
Yes.
79, yeah, I think she
that's
might
where
be
I've seen
81
it too.
now.
I've seen
Yeah.
it with the older gals who have required a dose reduction, but it seems to help. You know, it's generally manageable.
has
I mean, I do
850.
think that it's an important point, just because even if you look at the pellet data, you know, the pallet data, the randomized neoadjuvant study, there was a small percentage, about 4%, who had grade 3 or higher fatigue, right? So when we're rolling these out into the operable setting, you know, the allowance for that sort of side effect, we'll see how many patients end up coming off in the operable setting.
Yeah.
Really good
That's-
point.
Yeah.